I'm Keith Stirewalt, and I'll be talking to you for the next 45 minutes at most about revisioning end-of-life care. And let me give a few caveats here to begin with, or not caveats, just statements. Number one, I'm very thankful to Northwest AHEC for having me come here today. Got me out of the hospital, out of the office. That's always good. And I'm sure my boss is happy that I was invited out as well. Number two, I'm going to touch on religion, spirituality only a little bit in this talk. And of course, around end of life, you'd expect to hear more. I actually do hour and 2 hour talks on that. It can be very complicated and very individualistic. So please don't assume, since I'm excuse me, a chaplain, that I'm just blowing off religion, right? Because that's not good for me keeping my job. The third thing is, as someone who occasionally preaches, and only occasionally, and you'll get a sense for that as I finish, why? I'm used to being the last speaker before lunch, right? I'm not used to being the speaker in between sexually transmitted infections. And, right, so, you know, it's a new thing for me. So, and I'm going to say, I'm going to hang around afterwards, so if we run out of time for questions, frankly, I enjoy learning from audiences. I've never had an original thought in my life, so this is a culmination of different things that I've come up with. So here are our goals. We're going to discuss some of the common fears and concerns and perspectives of older adults as they approach end of life. We're going to try to assimilate some alternate views and frameworks for end of life care. I'm going to talk a little bit about black fire and white fire. Comes out of the rabbinic tradition. That's pretty tricky for a Baptist minister who goes to a Moravian church, but I can pull it off, right? We'll talk a little bit about healing versus curing, grief versus mourning, and Therese Rando, if any of y'all know any of her work, and then Leading Causes of Life by Gunderson and Prey. The other caveat, I changed my slides yesterday. When I do preach, you'll see me furiously scribbling on pieces of paper right before I go up. So my apologies. If anyone is masochistic enough to want to look at my slides again, email me. I'll give you the email contact, and I'll be happy to get back with you. So let's realize at the beginning that effective approaches to end of life are really contextual and bilateral or bidirectional between the clinician or the clinical people and patient family nature. There is not a one-size-fits-all for end of life. And conversations with seniors about end of life need to be nuanced through autonomy, beneficence, non-maleficence, and justice, what I call the bioethical quadrilateral. Can you tell I'm on the bioethics committee? So you're going to get a little bit of that today. Invisibility at end of life is a consistent fear for seniors. So let's talk a little bit about black fire and white fire. It's actually a concept I use in a lot of the work that I do these days. Most religions have some kind of codified text, right? It may be that some are all verbal, but we have words, those of us who follow individual religions or spirituality, that we hold on to. And so it's actually a Jewish classmate of mine at Wake Forest Divinity School. And by the way, I started off this trip as a physician assistant for a couple decades, and then got an MBA, and apparently thought I was making too much money and had too much power, so I quit and went back to divinity school. And so this will not be on the test, but what are the rarest words in the English language? Oh, that's the chaplain's Porsche. Yeah, you never hear those words, right? Not something you're going to hear from me anyway. So most of us, though, have some kind of codified text that we go with. And the truth is, we wrestle over those words. That's the black fire that can burn us. But my Jewish friend let me know about white fire. And that is because that we live most of our lives, and the end of our lives, in the white space, in between the words, in between the lines, in between the pages. It's those spaces that still can burn us and we still wrestle with that I will address today. So our tendency, I actually teach some at the med school. I teach a class there along with about 30 other people. That's my cane. About 30 other people, and then I teach some for the PA school and some for nursing. Our tendency is to want some kind of really neat formula, right? We want to see someone saying, well, I want or don't want this at the end of life. But it's not quite that simple, because as I talked about those white spaces, end of life for most of us is a white space. So the question is, how can we be intentional about experiencing the white fire with our patients and with ourselves about end of life, and how do we honor those spaces? So let me give you a little bit of the Chaplain clinical lens. I'm going to throw this cane down. I'm not healed, so this is not a TV ministry. Yeah, I didn't jump on the hurt foot. So your parents probably told you nothing good can happen after midnight when you're the chaplain on call at Baptist Hospital, because we don't have usually normal deliveries there. It's very rare. You don't get called for good things when you're on call at night. And so I was called about 2 o'clock in the morning, and I called of all places to the Bagel shop, which is no longer there. And I go and I find a woman in her late 60s, early 70s, sitting literally wringing her hands. No one else with her. And I sat with her and introduced myself and tried to find out how I could help her. Now, here's what had happened. She woke up about a few hours earlier. Her husband was making gurgling sounds. He had a stroke in evolution. He was brought to Baptist Hospital. She was told that he was not going to live, that he was going to stop breathing before too long. And the question was, do you want us to put him on a ventilator? Now, we could talk a whole hour about that. I spend a lot of my time on end-of-life stuff. So beyond that, my job was to help her. And so I said, well, tell me, in the past when y'all talked about being sick and too sick to speak for yourself, what has he said that would indicate what he would want done? And she said, we never talked about it. So despite being married over 50 years and sleeping in the same bed and raising 2 children to adulthood, being across the dinner table, they never discussed the what-ifs about end of life, or if I'm too sick to speak for myself. And folks, that's fairly common. I won't ask for a raise of hands here. If you look in the public, by the way, and most studies, they say about 30% of people have had some kind of direct end-of-life conversation with their family members. If I ask medical people, about half of them raise their hands. What does that mean? There's a bunch of liars in the room. I'm going to tell you right now, because I work with some of them when they get sick. We're not any better at doing this, unfortunately, than the public. That's part of the problem. So, again, called 2 o'clock in the morning, with someone who's dying, but still able to talk. Now, on television, what happens? Father Cook, who's the Catholic priest that covers Baptist Hospital, says the problem is every time he shows up, people think what? I'll be dead in minutes, because that's what happens on television, right? And he has had, and I've had this happen too, he's walked into a room and introduced himself and had people scream. And I had not obviously garnered this from a lecture. I was actually in a room one time and introduced myself as the chaplain. She screamed a bloody yell. This is the truth. I turned around because I was sure somebody had an axe or a knife or something behind me. It was not what I anticipated. I came into chaplaincy again as a practicing PA. I was going to be God's gift to chaplains, by the way. I was not. I'm not now. It wasn't about confession. No one said, well, I shot a man in Reno just to watch him die, and I need to let you know that. Here are the consistent things, and actually these go to all of us at all ages. There are fears about pain, not wanting to be in pain. Anxiety is a big one. We're really big about pain scales, but we're not as good about anxiety scales. Financial. You know what? I'm afraid that this hospitalization has cost every penny that we've got. I'm leaving my family with nothing. Fractured relationships that haven't been repaired. Isolation. There's a fear of dying alone. There's also a paradoxical fear of having your family members watch you die. And the one really common theme is life's narrative vanishing, losing their voice. Because the truth is, most of us tell stories. That's all I have is stories, right? And those stories are the tapestry of our lives. And so after I'm gone, who's going to know about that tapestry and to pick up on that? In Best Health, every couple of months, they unleash me on the public. I don't actually see patients much, except for those wanting to donate kidneys. And who shows up at my talks? It looks like the average church crowd. That means gray hair and bald spots. They look like me. That's who shows up. You don't see a lot of young people who are there to talk about end of life or serious illness. Because when we're in our 20s, we're never going to get sick and never going to die. Here's a theme that comes up, and it's consistent. I'm not sure who's going to make my decisions for me if I get too sick. Will my doctor start ignoring me? If I do one of these living wills, will my doctor start ignoring me? Will my family be able to let me go? Will they make the decisions that I want? Older folks, and I deal primarily with the geriatric population other than my kidney folks and the med school students who are 12 or 13, this is what we experience. Have y'all done this yet? And you're filling out something online, or you're filling out a piece of paper, and all of a sudden you're in that age group that, boy, you can tell really doesn't count again. And it's 35, and I'm a long way past 35. So again, the common themes are fear, experience of loss of voice, no one listens, or no one who listens. What Karen Scheib, and by the way, I've referenced her book in the back, calls invisibility. She's done extensive studies with older women. And by the way, the question in this book was, how do you feel older women are perceived? And the best quote I got, that was a synopsis, a lady said, old women are invisible. Don't you know that? We're invisible. That's the way many of our aged population feel. They feel like we think that they're bothering us. Sometimes they overtrust institutions. Part of my job, part of your job, right, is to enhance the concept of autonomy. I've had folks in my talk say, wait a minute, you mean we can ask the doctor if there's something else that we can do? So some of them come from a generation where you didn't ask. The doctor said, take this pill, and what'd you do? You took this pill, or at least told them that you did. That's from Monty's talk earlier. We have to empower them to be able to ask questions about what's going on. They also think it's being disrespectful sometimes of talking to their doctors. And it's questioning the provider's abilities. And there's this assumption, again, of marginalization and discriminatory treatment. My doctor really doesn't pay attention to me when I talk. So again, we're going to remind them of their voice through autonomy, and we're going to intentionally empower them. The healthcare agent, and this is not a talk just about living wills and healthcare powers of attorney, but I will say one of the best conversations that our patients can have with their family while they still have medical decision-making capacity is about what's important to me if I get too sick to speak for myself. So these things need to be proactive. What happens in the hospital? Now, we have chaplain residents who do the real work at Baptist Hospital. We got a slew of them. They're all younger, smarter, and prettier than I am. Frequently, when they're called to have these conversations or to lead these conversations with patients, patients are within a very short span at the end of their life. We don't talk about this in advance because you know what? Here's one of my theories. No one in Winston-Salem has cancer. Why not? Because they have cancer. We whisper it. You can hear your patients, you can hear their family members whisper as if it gives it voice. We need to emphasize with our seniors, and actually with everyone, that they need to gain their voice. And part of gaining their voice is by having someone that they choose to make medical decisions for them if they get too sick. And that doesn't always mean death, but this is empowerment. Margaret and I are going out on date night, which means what? We're going down 421. We're headed to Costco, because we're in our 50s. We're pretty wild like that. Actually, driving 421 is the most dangerous thing I do. That and the employee parking deck at Baptist Hospital. As I like to say, as a chaplain, I see lots of tears and anger, but that's in the parking deck every morning at Baptist Hospital as we fight over even the handicap spaces. So we need to convince them that having conversations with their providers as well. That's important, not when you get that 2-minute warning, because we don't always get that 2-minute warning, do we? So I may be driving down 421, or in my case, usually riding, and we could get in an auto accident, and suddenly I have a head injury and can't make decisions for myself. Here's some other commonalities about older folks that I wish I knew back when I was a young PA, because I was young once, seeing patients. A lot of times our seniors see a visit to their medical provider as a social occasion. People would, dress up a lot. I would think, why are you wearing so many clothes? I got to go through like 4 layers to get to you. But we fail to realize loneliness is pervasive in all generations, but especially in those who are older. Fear of looking dumb. And by the way, that's something that goes across as well. So I'll have patients say, well, I don't want to ask questions because I don't want to look stupid. That doctor's kind of smart, and I don't want to make him think that I don't understand. So part of our empowerment is the empowerment to say, you know what, doctor, I have to be honest with you. I didn't quite get what you said. Would you mind saying that again? Failure to follow the treatment plan due to misunderstanding. I've left the office. I've been in medicine since '78 in different ways, and sat in the car and thought, now, wait a minute, what did she say? She said to do something. The risk is, if our seniors or anyone leaves our office not understanding what their treatment plan is, what they need to do and not to do, or what their options are, there's a danger. So if we have somebody on an antihypertensive and they come back and they're still hypertensive, and we piggyback on that or add a second medicine, and then they decide to take the first medicine because they've got a check, all of a sudden they drop out, right? So there's some danger here. Whoops, and I hit the wrong button. That won't be the only time, by the way. So they may see the length of the visit, especially when someone's getting toward the end of their life, as a barometer of your respect for them. The Vulcan death grip is something I learned about in practice because I would have older women primarily, and I would go in and introduce myself and go to shake hands and get my hand grabbed and not let go. And it happened a lot. And finally, I said, why are you grabbing my hand like that? She said, as long as I have my hand, you're going to stay in here and talk to me. So again, they tend to see the length of visit. Now, one of our earlier speakers said, how long do we normally have with patients? 15 minutes. How much of that is actually face-to-face? Yeah, not much, because you're out ordering labs and things. They may be afraid to bring up end-of-life questions with you because they may think that you think that is, you're not thinking that they're a competent provider. They read body language a lot. And one of the things I do when I teach students of medicine is sit down. Put your rear end down. I don't care if it's against the edge of the counter. They can tell if you're antsy and doing this the whole time that you're talking to them, that you're already thinking about the next patient and get out. It doesn't take much effort to put your rear end down. You get a sense for why I'm not a church minister anymore. By the way, every church says, well, we want a real spunky minister. I can tell you that they don't, right out loud. Yeah. 3 years. I lasted 3 years, and nobody got hurt. Maybe I did. I don't know. So, they're waiting on you to bring up this end-of-life stuff. So it's a porcupine kind of phenomena. It's like having two porcupines in a real small room. Nobody wants to move because they're afraid of hurting the other person. But what happens is then somebody ends up in the bagel shop at 2 o'clock in the morning. Being honest with our patients. Again, we act sometimes like not only are we not going to die, but that our patients aren't going to die. Adult patients deserve, and a senior adult's medical decision-making capacity when they have it, not to talk to the oldest daughter over their shoulder, right? The bombastic oldest daughter that occurs. One of the questions that when we talk to our students about how to talk about something very serious and something that's going to threaten end of life, it's okay to say, how much would you like to know about your illness, right? And because when you talk to family members, and again, this has happened with parents I've talked to who've had young children and they've received very bad news. They hear bad news, and then what else do they hear? Nothing, not a dang thing. So silence, we are very uncomfortable with silence, but silence is one of our best tools there. So yeah, we talk about feedback, teach back kind of stuff. That's good, but giving them time to take it in and realizing this is a tapestry. This is not, we're not taking a photo of one thing where we say, Keith, I'm sorry you have ALS. We are looking at where I am right now and judging, using our clinical judgment, right? And then maybe the next visit, again, you're going to repeat that question because I might say today, I've had all I can handle, but next week I might want to know more. Next week I might want to know less. Warning shots and small bites. Again, you don't just sit down and say, I'm really sorry, but your son is going to die. And I've actually heard that said. One of the other things I've heard, by the way, is when I would be in the ER, there was one particular ED fellow who's not there anymore, thank goodness, thank God. And I got caught twice because, again, it's 2 o'clock in the morning, and he would say, well, I'm sorry that your mother died, and you know what, our chaplain's here. He's going to explain why God would do this. And he left. He left. I wish I was making this up. And the second time I got caught, it's a good thing I didn't have a cane back then, because he'd had one of the other residents treating him. So again, giving warning shots is okay, and to be able to say, I've got some tough news for you. Follow through. Life-threatening illnesses involve anticipatory grief and mourning, and further complications occur when we have the caregiver of the couple get sick. Another, I keep talking about 2 o'clock in the morning. That was my magic time period, apparently. I had the same call from the same intensive care unit. The caregiver of his wife had dementia, had a stroke. The family kept dropping off Mom at the hospital and leaving her, and she would be found wandering around. That's pretty sad, isn't it? Right? So we have that happen. So Rando talks a bit about grief and mourning, and I love her. And I also like that I can use references that are not 6 minutes old. Well, one of the things that we tend to want is we want to study or a book that came out yesterday. Rando's been around for a while. I don't know how old she is, but if you ever get a chance to hear her speak, and I've given you one of her references, she talks about the difference between grief and mourning. And you have this on your slides, but just remember that while grief, and she said grief is a craziness, but grievers aren't usually crazy. That she describes the bad things we do to people about mourning. It's been a year. Don't you think it's time to date? It's been a year. Don't you think it's time to get over this? Mourning is a lifelong process as we continually get used to living without the other. Advanced care planning and geriatrics, more than just about end of life, as I said. This is about giving voice, and we need to, I'm trying to look at the time to make sure I don't put my thing is not working here. So what time is it? So that I'm going to hear your stomachs all growl at noon, but 11:30. Thank you very much. Advanced care planning is more than about end of life. It's about who's going to take care of us, who's going to take care. And it's a lot less intimidating if those of us in the room have had the conversation, right? If we've done a living will or a healthcare power of attorney. My colleagues who helped teach the class I did, we actually did a little informal around the table. Many of these are ICU physicians. I was amazed at how few of them have actually done these documents because, again, we're uncomfortable with the conversation. One of the things we tell folks to do is this is a good day after Thanksgiving conversation because by then you're kind of sick of each other anyway, and you can pull it, but everybody's still at the house and folks haven't left yet. But again, if I could say, and as I do with patients, this is so important that I have one, right? And I don't have anything that I know of that's going to kill me anytime in the near future. But what better barometer? We need to normalize these conversations. Death has become very abnormal in our culture, and it started around 1900. But we also have death as medical misadventure. These days, if someone dies, the thought process is either we did something to someone we shouldn't have, or we didn't do something we should have, right? One of the two. So we need to not to be morose about it. My family, by the way, has 2 advanced care planning conversations a year. Now, we're not the Adams family, for those of y'all who are old enough to remember what that is. But my boys who are 15 and 19 are involved in the conversations and will even say, well, I want to be cremated, or I want to, one of them wants to give his body to the medical school, which is nice. By the way, speaking of cremation, there's a lot more of that coming on, and that's one of the conversations that we really need to have is about burial and cremation. Sometimes it's a religious conversation. Years ago, I was telling one of my chaplain colleagues at the time that I decided to be cremated, and she said, "You mean you're going to burn twice?" Ooh. So I thought, now that's a great line. So I was speaking to a really large Baptist church, and I said, "You mean you're going to burn twice?" And nobody said anything. Now, it usually works, works well, but boy, and I never got them back either, I'll tell you that. I might as well just said thank you very much and walked off. But just remember about advanced care planning for all of us, and it just works better. It makes it less intimidating if we can say we've had conversations with our families, whether or not we've done the documents. So it can have legal documents. We can talk a little bit about portable medical orders, but we don't want our patients to misunderstand this as, well, we've given up on you, right? Abandonment is a big issue for all of our patients, especially our dying patients, especially our seniors. So it's conversation about our goals for medical care before serious illness occurs, and we should view these as acts of love and justice. A lot of our folks who are in our hospital these days don't lie there and trust the medical system. Some of it, cultural, is a road that we paved. I have a book in my office called Medical Apartheid, which is a thick book, and it's nothing but things that we did to the African American community that really were really uncontrolled studies are bad things. We all know about the Tuskegee. So realize, and for our rural folks as well, there's a distrust that we don't care about them. If folks are there on Medicaid, well, they're just going to try to get me out as soon as they can. So all this is going on. So we need to let them know that choosing someone to speak for them when they can't is an act of justice, because it's carrying forward your voice, what's important to you. There's a love aspect to this as well. Now, we won't have time to go over the documents, but at the end of the document on the living will, and actually it was created, Navat and where did I work? Wake Forest Baptist Health, that's it. I've only been there 6 years. Actually came together with a lot of elder law attorneys because we saw the document that most folks use as living wills and healthcare powers of attorney was way too hard to understand. I was in meetings where attorneys argued about it and thought, how do we make our patients understand this if attorneys can't agree? So we created a new one, but the last question is, what if your living will says this and your healthcare agent says this, right? Because sometimes out of love, they may say, you know, Margaret may say, yeah, I'll let you go when it's time, but maybe she loves me. She seems to. She wouldn't put up, like I said, I don't make money anymore, so there must be something holding me there. What do you do when it's separated? So you can choose, well, you know what, if those things don't agree, listen to my healthcare agent. Just listen to whatever they say. Because the truth is, you know, I'm not going to be around to hear it anyway. That's actually what one of my colleagues said. So when this came out, I actually checked the box that said, listen to my living will. And I went home and told Margaret that I'd redone my healthcare power of attorney and living will. And I said, by the way, if you happen to disagree with my end-of-life wishes, my document says, listen to the living will. And she started crying. And I was able to explain to her this. Here are the things that I've heard as a clinician, now former clinician, and a chaplain. Don't you wish you'd waited a few more days? What if a miracle was going to occur? What if this were a test? This is a test by God, and you failed. These are things that I've heard commonly. What if they invented something new tomorrow? If they invented something new tomorrow, when would we see it at the hospital? Yeah. Oh, yeah, 10 years, you're being optimistic probably. Yeah, 10 years from now. So I said, I can't stop people from saying these kinds of things to you. But I can do this. I can give you the answer. This was so important to him, and he loved me so much that he took this decision out of my hands. Because this is a hard decision, isn't it? So as I told her and my boys, this is the last I love you that I'll ever say to them. So this is what we came up with. The problem is when we try to choose somebody to make our medical decisions, who do we normally go to? We go to our spouse. Our spouse is not always the best person to do it. I don't get to see patients very much again, but I had a couple come in. They were in their 60s. She had a brain mass. She was going to surgery on Friday. This is Thursday. She wanted to do a living will and healthcare power of attorney. When we came to who would make her medical decisions, the healthcare agent, he said, well, of course you're going to choose me. And she said, no, you won't even let a plant die. Oh, tears. An hour just talking through. No document done. Came back the next day. She chose her daughter, an intensive care unit nurse, right? And she'd had a conversation with her. And he understood his job was to be her husband and to love her in this case. By the way, not to make this sound like a very special movie of the week, it ended up being a benign mass, and the next time I saw him, he was, almost skipping through the entryway. So, again, it's not always our spouse. It's not always the oldest son. We hear that, because I'm on the bioethics committee and do some consults as well, and we hear, I'm the oldest son, so I make the decisions. No, it doesn't work that way. I'm the oldest daughter. I make the, it doesn't work that way. That we have a nice statutory tree that, I won't waste our time going through, but that's one of the nice things the state has done for us, is to give us a flow of who can make medical decisions. If you don't have a living will, it's fairly straightforward. The unnice thing is these have to be notarized. We're one of only 4 states requiring that, which is a significant hump. It's very difficult to get these done. So when you choose someone to make your decisions for you, it is not, again, a snapshot. It is not, if I'm talking about end of life, you and I don't have lunch and that's it, and nothing's going to change. Because I like to, I talk about death a lot. The nickname for me is Chaplain Death in the department. I talk to all kinds of people about end of life, different subjects. I'm not lying in the bed. I'm not the one with the diagnosis. So what I may say when it's me may be totally different than when I preach. And of course, we know that ministers rarely do things against what they preach, right? That's a joke. So when you're picking somebody, here are the 4 A's that I came up with. Affinity, you want your seniors to choose someone who knows them well and knows their values and cares for them. It is tempting. I have physicians who say, my patient wants me to be their healthcare agent. That's not generally a good idea. But you need someone who knows what's important to you. If spirituality is important to you, what aspects of it? What have you experienced loss-wise? My mom died not in the ICU. We were able to get her in a regular room. That was important to me. All those stories, again, that tapestry that makes us, these are important for your patients to be able to express what's important to them. Access, somebody we can get in touch with. That includes by phone. Assertiveness. We live in a world of white coats, don't we? And at Baptist Hospital, you'll notice it's like wildebeests. There are herds of white coats that come into a room. That's a problem right there, right? So, and y'all know the rule of the white coat, right? The longer the white coat, the more authority you have, right? And so we have some physicians who have trains that actually have people who walk behind them there. I'm not naming anybody because I like the job that I have. So again, it can be very intimidating. So if you're making my medical decisions and 7 people come in the room and say, well, we'd like to take Keith to surgery, you need to pick someone who can say, wait a minute, I know you're talking about surgery. What are you talking about doing here? What are the good things that could happen? What are the bad things that could happen? What if we treat this medically? What are the good things and bad things? And the question we often forget is, what if we watch and wait? Is there any problem with us waiting a day or waiting 2 days? What are the ramifications of that? So that takes a certain amount of assertiveness. Notice I didn't say rude. As I tell the folks who come to my clinics, you don't want someone who's going to be rude. That's like being rude to your waiter. Bad things can happen, right? You don't want someone being rude. You be assertive with them. But here's the other part of that assertiveness. That assertiveness also needs to translate to all the family members. So I was involved in a case 25 years ago, somewhere around 25 years ago, where a lady was very sick. Her husband, her second husband, had kind of checked out of the process and refused to make any decisions. She had DIC 3 times. If y'all know disseminated intravascular clotting, to get through it once is one thing and twice is another, but 3 times. She had had a difficult course. She had no intestine left. The distal third of her esophagus was gone due to cancer. And I stood there, and the surgeon said, well, I could take her back to surgery. And before I knew it, I said, no, stop. This is enough. And his shoulders went down, and I thought, oh, gosh, what's going to happen? And he said, thank God, I've been waiting for y'all to say, stop. This came out of a good part of him. That was my mother. And she was able to die a peaceful death, not having gone back to surgery again, not dying in the intensive care unit. If you want to know where my passion for this comes from, well, there's part of it, right? Who would make your best decisions? We're going to go through this quickly. So the last one with the assertiveness is assertiveness with family. We're going to talk about assertiveness with family and friends. Here's one of the deal, because frequently we will have to call security or go in and kind of wade in the middle of families who disagree. By the way, sometimes it's disagreement about what's going to happen to the body, but often it's disagreement about whether we're going to stop the ventilator. My Vaseline or my porcelain vase theory is that all families are like an old vase that has cracks in it. Sometimes the stress of healthcare, we actually come together and do well, but often the cracks get bigger and the water flows out. So just to be aware that it's a time of high stress and sadness. And despite the fact that usually when we're called, there's this suspicion, well, they just want to keep her alive so they can get another Social Security check. Often that's not the case. Often there's something deeper going on there. Why is there a seagull in the corner? Does anybody know what seagull syndrome is? Seagull syndrome is this, because whether it's bioethics or whether it's chaplaincy, we'll finally get a family to a place where they've come to resonance. They may not be happy with what's going on, but they come to resonance. And here's seagull syndrome. That's when the family member who lives the farthest away flies in like a seagull and poops on our plans. And it happens a lot. So not only is it funny, and it's going to be either that son who left and went to California who no one heard from for 20 years who suddenly shows up. I'm going to make up for being a bad son for 30 years by keeping you alive. Just know that these kinds of things happen. Again, another good reason, because without getting tied up in the statutory tree, once we go past either your healthcare agent or your spouse, it's then the majority of your available adult children and your parents, if they're still viable. It is a committee decision that's occurred. Now, if I learned anything in the church, it's that committees can be wonderful things and can be just horrendously draining. And it was somewhere around 10:30 at night in a House and Grounds Committee meeting. I used to be at First Baptist downtown when I thought, if I robbed a liquor store and did it poorly and got caught, I wouldn't have to go to another church committee meeting again. Another sign that I didn't need to be in the church. So acknowledgement. Hey, please have if your folks say, well, I'm going to choose my cousin Jester to make my medical decisions, and they do please have them talk to them, because it's not uncommon for someone to find out that they've been named as a healthcare agent on a legal document, and they didn't know. So another story, when I was a second-year resident, I did help with the living will and healthcare power of attorney on a man having open heart. He mentioned his son, so his son was going to be his healthcare agent, and as I was getting ready to leave, we'd done the documents, got it notarized and everything. I said, by the way, where is your son? Is he in the cafeteria? I haven't met him. He said, oh, no, he's in someplace like Topeka. I can't remember where. Out west. He doesn't know I'm here. I don't want to worry him. I drove home thinking, I can't make like stars and expletives up here over my head, thinking, oh my gosh, if things go south and they need to call, his son's going to find out he's in the hospital. And by the way, since I'm telling stories, this is another story in that same area, and that is a man said, I don't want to do one of those living wills and healthcare powers of attorney. And so I explained to him the North Carolina statutory tree, which said your legal spouse will make your medical decisions. He and his legal spouse were in the midst of breaking up. They hadn't quite broken up. She had thrown a toaster oven at him 3 days before. He decided to do a new healthcare power of attorney and name somebody else. Because he just knew what she was going to do. So just realize, of course, you've probably seen these, the North Carolina portable medical orders. One is a portable DNR, the other is a MOST. These documents are, unfortunately, are just not used near enough. And I go from city to city and hear the same thing. We have folks who have a terminal illness and haven't yet either been told or understand it's terminal and show up in the ED and hear that they're terminal for the first time. Are the family members here? Well, he's only got about a week or so anyway. These are valuable documents. They have to be signed by somebody licensed to practice, nurse practitioners. I know we have some in the room. PAs and physicians are the ones that sign them. Here's the disadvantage in the state. You have to have the original form. So let's just say that my physician fills out a MOST order on me, a medical scope of treatment, and I've decided I don't want CPR, and I don't want to go to the hospital unless you can't maintain my comfort somewhere else. But I go to Harris Teeter, and I fall out on the floor there, and I go into a fatal arrhythmia, and EMS gets called. They must attempt to resuscitate me and take me to the hospital. I have to carry this thing with me. So if you have patients that have these, please tell them to, number one, if they're bedridden, have it in a consistent place. Actually, in Virginia, they ask people to put stuff in their freezer in a bag. Does anyone out here do that? Your freezer must be a lot neater than mine. I can't find ice cream sandwiches. I don't know. So, to me, there's a danger in that. But at least have the family members know. Now, another problem about having to have the original, family members panic, and what do? So they know that Keith's dying of cancer. They call 911, and what happens to that pink form? Poof, gone. Yeah. So these are very valuable for your patients for whom this question comes. Would you be surprised if this patient died within the next year? What's the hospice question? 6 months. So the surprise question for the DNR and the MOST is a year. Now, I'm a pessimist. I wouldn't be surprised if all of us were dead next year. But so it doesn't. So my buddy in bioethics says, no, you got to tell people that's in context of their medical condition. But again, just know that is a valuable tool. So the Blackfire portion of this is the DNR. We always go into that question, but there's really much more of a question about what we want done to us at the end of life. So it goes far beyond whether we start CPR on me or not. What medical interventions do I want? Antibiotics can be life-prolonging, right? What was pneumonia called in the past? The old person's friend, right? Because it was a peaceful way to go. I've had family members who got treated 4, 5, 6 times for pneumonia who had no medical decision-making capacity and finally succumbed to pneumonia. Nutrition and hydration is poorly understood. The reason is now in the South, if somebody gets sick or has a baby, what do? It's casserole theology, right? We show up at the door with a casserole. So if food equals comfort, lack of food equals discomfort. Yeah, and so, Keith is starving to death. Now, guess what? If I'm dying and I still have a sense of hunger and I still can eat without aspirating, what do? We eat. Yes, it's really very simple, isn't it? And yet, when families are sitting there thinking, we got to do something. Keith likes those Whoppers with cheese, and he's never seen a day without a corn dog. They want a peg tube. They want something like that. We need to be able to explain to them that we actually can harm our patients by doing that, right? Because our intestines are richly innervated, great blood supply, but toward the end of life, as our blood pressure goes down, those things stop working. You put a peg tube in me and start squeezing stuff in, discomfort, abscess. Likewise, we all know that our kidneys stop functioning or get low functioning toward the end of life. Fill me full of fluids. Where does the fluid go? Yeah, Michelin tire man kind of thing. So just be aware that our patients have a really poor, actually medical people sometimes as well, a really poor understanding of the efficacy of CPR. I attended a bioethics conference, and someone at least claimed they'd done a study of television patients who received CPR. What percentage? Anybody got a guess? What percentage survived? It was pretty close. It was 80%. Yeah. And again, they're eating that Whopper with cheese by this afternoon. I was in the field for a while. I worked in the emergency room for a while. I don't know that I ever saw a successful CPR in the field. Not that it doesn't happen. And, AEDs have made a big difference here. But now look at this. This is for people with a chronic illness in the hospital CPR, right? That would be best, right? So when looking at those who had one of these chronic illnesses, so let's start off with those who didn't have chronic illness and who had CPR. 7.2 of those recipients were discharged and still alive without readmission at 6 months. That's pretty low. But if you had one of those chronic diseases, less than 2%. This came out of Chest magazine in October or November, I think 2 years ago. Really poor. So very quickly, because I am running on time here, Gary Gunderson, and I need to mention this, she's got the 5-minute thing. I need to mention this because he's my vice president who wrote this book. Gary, when he signed my book, he said, what should I write? And I said, you should say, I'm still not sure what you do for a living. So these are things that he points to for all of us. Here's his point, and Larry prays. We spend a lot of time on the leading causes of death, right? I still read all my PA stuff. Leading causes of death. He said, what are the leading causes of life? So they actually did some studies, and some of it was subjective, some of it objective. What are the things that tend to lead toward not just a good life and a long life numerically, but a good life in terms of life enjoyment? And so these are the ones that they came up with. Connection. That includes social and spiritual. Again, a lot of our seniors are lonely. When I was in primary care, a lot of my younger patients were lonely as well. Some of them had families and children, and they still were very lonely. So connection to others. That's what Faith Health does. A few years ago, I think someone from Faith Health, I'm in that division, came and talked about that. Coherence, the desire for an authentic voice in our life. Again, that's part of keeping our voice. Agency goes along with the autonomy from the quadrilateral of bioethics, the capacity to act and choose. And again, even if we're intentional about hearing our patients' voices, realize that there may be other people in their lives trying to talk over them. This is the last anecdote I'll give. I was seeing an older patient one time who was having some urinary symptoms, and his wife was there. She kept answering all the questions. So I asked, do you get up at night? How often do you get up at night to pee? And she said 3. And I guess I got exasperated, and the filter between my brain and mouth disappeared, and I said, That was neat. I never even saw your lips move. Well, I saw from him a really sly smile. What I received from her was not sly, nor was it a smile. And I never saw them again. So it wasn't a smart thing to say, but, I do dumb things occasionally. So the capacity to act may look like someone's got the ability to make decisions, but there are people who are trying to steal their voice. Hope is contextual. Hope exists all the way to the end of life. This is what we hear. Oh, well, so there's no hope then. Yes, there is always hope. There's always something else we can do. And I'm not talking about scratching your head and saying, there's a Norwegian study of left-handed Baptist, and this medicine, it's new, but we'll give it a try. That's not hope. Hope is we're going to be with you. Hope gets reframed, right? Hope changes constantly. I'm not going to abandon you. I'm going to pay attention to you. Hope is knowing that you're going to spend your last days surrounded by people you love and who love you. There is no greater gift than that. And that's part of blessing as well. So, how much time we got? 3, 2. I'm hearing stomachs as well. So let's remember again, a lot of this in end of life is about, with our seniors and actually all of our patients, helping them to gain voice and bringing this in slowly. You don't just pop in and say, by the way, if you died tomorrow, again, talk about it when the patient is healthy. Talk about it with your family when you're healthy. Don't wait. Now, up until a few years ago, we used to talk about, we need to look at the way doctors die, because that's the way we all ought to die. And that was really good until someone actually did a study. And it turns out, this was in the Journal of American Geriatrics a couple years ago, for physicians, inpatient use in the last 6 months of life was no different than the general public. They were slightly more likely to use hospice, but they were more likely to be in the ICU in their last months of life. So the truth is, we all have a lot of work to do ourselves about how we deal with death. And we've got to reconcile that before we can actually work with our patients. So one slide synopsis: emphasize to your geriatric patients that you value them and that you're going to work toward healing even if cure is not there. You're going to listen to them. You're going to really listen to them, right? And you're going to care for them and be with them through their journey. This is one of my favorite things. This is Jacob wrestling with the divine being. My wife, by the way, says my favorite book of the Bible is the book of Kethus, because I tend to make stuff up a lot. But here's my synopsis. Reconciliation with the mystery of nature, including our own finitude, our end of life, isn't found at arriving at a comfortable answer, but in arriving at comfort with the questions. Thank you all very much.